Good afternoon, everyone. This is Abbey Hughes and Dr. Meghan Beier. As Mohammed mentioned, we are assistant professors in the Department of Physical Medicine Rehabilitation in the Division for Rehabilitation Psychology and Neuropsychology. We work predominantly with individuals with multiple sclerosis, and today we would just like to touch on a brief summary of some of the common mental health issues that people with MS experience and how that may come about in typically a primary care setting or other physicians who may interact with people with multiple sclerosis maybe outside of the neurology clinic. I see from our attendance we have 8 people on the webinar. I'm not sure what your backgrounds are, but please feel free to type in some questions and we'll try to address those as we go along. And certainly we will have plenty of time at the end to answer your questions and potentially have some discussion. We're very open to any questions you have as we go through. So we'll go ahead and get started. The objectives for today is by the end of this hour, we'd like you to be able to identify the most common mood symptoms for people with MS as well as the common mood symptoms for their support partners. This can include caregivers, spouses, family members, etc., all who are impacted by MS in various ways and may then experience mood symptoms as a result of that. We'd like you to understand why mood issues are so important to identify. And as you'll see throughout this presentation, there's several barriers to identifying mood issues, and it's a very underdiagnosed problem for our patients. We'd like you to learn basic tools for assessing mood in your clinic, especially even in a fast-paced primary care setting where you have very limited time. We offer some very brief tools that may help you in terms of decision-making of when to refer patients for psychological services. Importantly, we'd like to review some case samples. MS is an incredibly heterogeneous population. There are many different ways that rehabilitation psychology can be helpful for patients, and we'd like to showcase some examples of that. And finally, we'd like you to understand the role of rehabilitation psychology in MS care, which is very collaborative, and we work with, of course, neurology and other providers within the PM&R department and throughout the hospital. We do want to provide a brief overview of MS. Most of you, if you are providers or physicians, you've probably had some experience or at least a few patients you've seen with MS, but we do want to cover the basics. So MS is a neuroinflammatory and neurodegenerative disease of the central nervous system, meaning it affects the brain and the spinal cord. And specifically, MS attacks the myelin sheath of the nerves in the central nervous system. So as you can see in this image here, lesions or damage to the myelin can occur anywhere in the CNS, including the brain and spinal cord. When the nerve is affected, the myelin sheath is destroyed or damaged. That can disrupt the signal so that neurons cannot communicate with each other. That can result in the disruption of the signal and or the death of the neuron. So we have not only neuroinflammation, but also neurodegeneration in the presence of atrophy, or which is observed on MRIs as well. And as you can see, this is a pretty hallmark example of an MS MRI image where you see some paraventricular white matter lesions. These are pretty hallmark of MS. They're usually disseminated in space throughout the brain, and these are enhancing lesions. MS, as I mentioned, is very heterogeneous. There are many symptoms associated with MS that people may present with upon first diagnosis and throughout the course of their disease. You can see the text in red highlights the symptoms that are most common. So those include a lot of the physical symptoms, such as the numbness and tingling, fatigue, which impacts upwards of 90% of patients with MS. Walking difficulty is fairly common as well. But then if you take a look at the dark blue text as well, you see some of the other symptoms that are also affecting more than half of patients with MS. These include depression, cognitive dysfunction, bladder dysfunction, other emotional changes, and things like headaches and dizziness. And that's really where our role can come to play, is helping patients manage these symptoms that do affect over half of our patients. And specifically, the depression and other emotional changes can be significant. A brief note on prevalence. So we know that MS tends to be more common in the higher, more northern latitudes, around that 37th parallel. And we see that Baltimore is right around the 39th parallel, so it's just north of that. So we do see more patients here in the Baltimore area compared to more southern regions of the U.S. This is also common in Europe, so it is a disease that affects more northern latitudes. And so now I will hand this over to Dr. Beier, who will speak a little bit about the symptoms that we're discussing today.
Okay. So as Dr. Hughes said, we are focusing the talk today. We could spend a lot of time talking about any and all of the symptoms, but we're focusing the talk today on emotional symptoms that are common to MS. And this is a picture that was drawn by a child of an MS patient and that child's interpretation of MS, so the very nervous system in many ways. A little bit of a historical perspective, depression, mood changes, and cognition were noted by Charcot, one of the early neurologists who wrote about MS over 100 years ago. The take-home point is that, even though he noted these symptoms were quite common in his patients, this was promptly forgotten and not looked at until just a few decades ago. In the 80s and 90s, there was sort of a resurgence that depression, anxiety, and cognitive symptoms are actually quite prevalent and something that should be considered both clinically and from a research perspective. I'll highlight two areas that are really common mental health symptoms. So depression can occur in up to 50% of people with MS. And anxiety, although it's kind of the forgotten symptom or the forgotten mental health issue, can occur in up to 40% of people with MS. It's actually 3 times more common than the general population. And the two of these things together can actually exacerbate thoughts of suicide. And so it's really important to look at both depression and anxiety. Another factor that's quite common in MS that's not necessarily wholly an emotional distress concern is pseudobulbar affect, and Abbey, Dr. Hughes will talk about that a little bit more. Depression and anxiety also are quite common in support partners and can impact the care that they provide for our patients with MS. So a little bit about specifics in terms of depression. People with MS and their support partners, as I said, are at risk. So up to 50% of people with MS will experience a diagnosable depression at some point in their life. The depression not only impacts them in terms of their daily functioning and quality of life, it's also linked with things like cognitive impairment, which can impact relationships at home and at work in terms of their ability to communicate, to problem solve at work, and to really engage with the world around them. In terms of depression in MS, there's more research now more than ever that depression is likely not only just a reaction to the disease, but actually a symptom of MS itself. There's quite a bit of research that shows that there's anatomical changes in the frontal and temporal lobes of people with MS who also have depression. A little bit in terms of breaking this down, early on in the disease and in people with an inflammatory profile like relapsing remitting MS, the depression tends to be linked to that inflammatory process, so occurring before, during, or after an exacerbation. Later on in the disease, or people with progressive MS, depression seems to be linked more to cognitive issues in terms of maladaptive thoughts or more of a reaction to changes in life. So it can be both a aspect of the disease itself or a reaction, but what we know is no matter what the cause is, that treatment in terms of cognitive behavioral therapy or antidepressants is effective at mitigating these symptoms. We also know that, as Dr. Hughes touched on earlier, that depression is underdiagnosed and undertreated. There's one study that shows that up to 2/3 of MS patients are not receiving or never have received treatment for depressive symptoms. And of those that did receive treatment, only 25% were on the adequate dose of an antidepressant. So it's really important in your MS patients that maybe are exhibiting some depressive symptoms to figure out whether or not they have been offered some form of treatment and whether that treatment is adequately addressing their symptoms. Up to 50% of people with MS and depression will also have anxiety. So it often co-occurs. Anxiety can also present independently or without depression. Anxiety is almost more important to assess than depression sometimes because it's highly associated with more problems in daily functioning. So people with anxiety and MS are more likely to have alcohol abuse issues. They're also more likely to have suicidal ideation and act on suicidal thoughts. Up to 15%, now there's mixed research on this, but up to 15% of people are thought to die by suicide in people with MS. So it's very important for us to assess these symptoms, and asking about it is not going to increase someone's risk of suicide. Currently, many providers focus on depression but don't ask about anxiety, and we'll give you a tool later on that's 2 short questions that could help you easily assess for anxiety in your clinics. And as I said, anxiety is even more disabling because of potentially avoiding the things that they fear or, again, that risk for self-harm.
And finally, in addition to depression and anxiety, there's also a presentation of mood issues that falls into this category of pseudo-bulbar affect. This presents as intense emotional lability in patients who may cycle through extreme bouts of crying or laughing, inappropriate to the context of the situation, cycling rather rapidly, and not necessarily in concert with the actual intensity of the emotion in the room. So patients may find that they very easily cry about something that isn't necessarily even something they feel sad about. So they may be crying but not stating that they feel sad, or they may be laughing and not saying that they feel that something is funny. This is generally thought to be because of a disconnection between more frontal and temporal cortex functioning and cerebellum. There's disrupted connections, again, due to that demyelination or the disrupted neuronal signaling pathways. There's a number of neurotransmitter pathways that originate down closer to the brainstem and project toward the frontal lobes, and it creates a cycle or a feedback loop that normally, for most of us, helps us determine if we're responding appropriately emotionally to a situation. For these patients who are experiencing pseudobulbar affect, that cycle in some ways is broken. And so that's also something to keep in mind, is that if you're seeing a patient who seems to be either cycling through these extreme emotions or reporting kind of these bizarre experiences or unusual experiences of uncontrollable laughing or crying, it may not be something like anxiety or depression. It could fall into this more pseudobulbar affect. It's also important to note that this can be caused by not only brain lesions, but also the overall atrophy of the brain. As I mentioned before, with demyelination, that can disrupt the myelin and create these MS plaques, but also death of the neuron and overall brain shrinkage can also disrupt those pathways. A final note would be that steroid use can increase risk of presentation of the pseudobulbar affect. About 30 years ago, if this presentation occurred, some people would describe it as a psychotic break or having a psychotic reaction to steroid use. But what we know now is it may be more of this pseudobulbar affect. It's often treated with amitriptyline or other antidepressant medications. Sometimes it's temporary as well, and after ceasing the steroid use, mood returns back to normal. So these are all, with brief questions in your interview, you can sometimes get at whether something is truly a depressive episode versus something more like pseudobulbar affect. On this slide, I really want to highlight some of the misconceptions
with mood disorders and MS. And the main point I want you to take home here is that depression, anxiety, and these mood changes are not just, oh, anybody would feel this way. There are plenty of people with MS that do not have depression or do not have anxiety and are quite resilient. So it's not just necessarily a reaction to having a chronic medical condition. And like I highlighted earlier, there's plenty of evidence to show that sometimes these symptoms are actually a symptom of the disease itself. The increased rate or risk of suicide is not understandable or inevitable. It's something that can be treated and should be assessed for. People with MS don't always look and act depressed. Sometimes depression looks like irritability or anger. And similarly, people with MS are not always depressed. The visible symptoms of MS, such as walking issues, gait issues, are not necessarily the most disabling. Some of these invisible symptoms that we've touched on in terms of fatigue and cognition and emotion can be just as or even more disabling. And cognitive dysfunction is not independent of emotional symptoms. So depression can impact or can be a symptom of changes in the brain. Fatigue is one of the most common symptoms of MS. Somewhere around the 90% of people with MS have fatigue. And there's some research to suggest that CBT is, for cognitive behavioral therapy, is something that can positively impact fatigue, meaning that fatigue might be a symptom of depression. So if individuals are coming in and describing feeling tired throughout the day or really having no energy, depression might be something to look at. And grief and depression are not the same thing. So grief is a reaction or an adjustment to the loss of a function or a change in what one perceives their life to be. And it's temporary. It's not something that lasts for months or years at a time. And depression is something that is long-lasting or functionally disabling.
So for those of you who may be new to our service or have not worked with a rehabilitation psychologist in the past, we are a little bit different than maybe a traditional clinical psychologist in that we truly focus on individuals who are living with chronic diseases and disabilities. So we have many psychology services through Johns Hopkins and in the community, people who focus on many different disorders, many different conditions. With rehabilitation psychology, our focus is on enhancing resiliency, improving individuals' perceptions of their self-efficacy, and also doing thorough assessment to identify what are some areas of weakness that could potentially benefit from intervention and improvement. So those things include things like cognitive dysfunction, which is common for many individuals with chronic or neurodegenerative diseases, including MS, of course. So within our department, again, the PM&R department, we have 2 dedicated psychologists, Dr. Beier and myself, and then we have multiple fellows who are dedicated to providing psychological services. That includes both assessment and treatment for individuals with MS. We also have rehabilitation psychologists who focus on other areas of rehabilitation and other diagnoses, including brain injury, stroke, recovery of cancer, and post-surgical recovery. So it's not just MS, but we certainly have a level of expertise with MS as well. So if you do have any questions in terms of the referral services, we will be describing that at the end of our program today. You can certainly place a referral through the EPIC system and request that the referral go to the Department of PM&R Psychology, and then our folks triage that from there. So you'll be able to reach either Dr. Beier or myself through that process. So we wanted to give a couple case presentations to show you some of the breadth and depth of what we typically do as we work with patients, and hopefully showing you that because of the range of patients, some may benefit from very brief therapy, really to enhance or contribute to their existing resilience or their existing strengths, whereas other patients who may have more needs, we can do a much more comprehensive treatment and potentially have longer-term therapy. So we'll give a few of these different examples. We'll give an example of Jane, not her real name, but Jane is a 53-year-old female with a 20-year history of MS. We didn't talk too much at the beginning about what the typical MS progression looks like, but most people with MS are initially diagnosed with the relapsing remitting form of the disease. This tends to cycle in and out of these exacerbations, most of which patients almost entirely recover from after a brief steroid treatment. Some continue to have some residual symptoms, both physical and cognitive and emotional as well, but for the most part there's that recovery process. About half of those patients, after about 10 years, convert to what's called secondary progressive MS. And so this is a more progressive form of the disease in the sense that patients are usually more physically or cognitively disabled or both. And they experience decline without necessarily the presence of these exacerbations or relapses. So depending on where someone is in the course of their disease, we focus on different aspects of psychological intervention and adjustment. Earlier in the disease, we may be focusing on adjustment to a diagnosis and what that means for education for the patient and their family. For patients who've been living with MS for quite a while, they sort of have all the education they need about what the disease is and how they cope. But when there's a conversion from this relapsing remitting form to the progressive form, there's often a new type of adjustment to that, maybe coping with new types of disability or role loss or work loss. So for Jane, she was a highly educated female, had a college degree, married with 3 children, and she was coping with her MS fairly well. She was on a disease-modifying therapy that was working well for her. She wasn't having many relapses in that time. And she was fully employed as a special education teacher until about 5 years ago. About 6 months before that, she began experiencing progressive decline in physical functioning, and it resulted in her stopping to work and pursuing disability. She had no prior history of depression prior to that period, but once she stopped working and was experiencing this progressive decline in functioning, she described several periods of sadness over maybe the past 2 years, where she experienced frequent crying. She described not feeling like herself and had a lot of uncertainty about the future. Now, typically, if this patient were to come into a primary care clinic and describe this, we don't really know based on this information alone whether this would be something that would fall into more of a depression diagnosis versus something more like adjustment. This person's gone through a huge life change and a role loss, working with something that was very important to her and to her family from a financial standpoint. It gave her a strong sense of self-efficacy, and this was a huge loss for her. So determining whether this loss and how prolonged this grief process has been for her, that tends to be where psychology can be helpful in distinguishing depression from grief. And so I like to show this image when we talk about how MS fits into the puzzle of someone's life, and you may have seen something like this with other conditions. But we all have ways that we describe ourselves. So we may have different personality factors or traits. We may feel like we're creative or disorganized, or I'm a mother, or I'm a father, or I'm a partner. I'm wealthy, I'm poor, I have my age, I have my other personality characteristics. And then suddenly you get diagnosed with a chronic incurable disease that you know is progressive and you're likely to get worse over time, but you don't know when you're going to get worse. It brings about incredible uncertainty, and it becomes this additional piece of the puzzle that doesn't necessarily fit into how people are perceiving themselves. And so for most of us, for people who are fairly resilient or who have lots of resiliency-based support, and that includes things like social support, which we'll talk about in a bit, they're able to integrate that puzzle piece in other ways. They may change things that were important to them that no longer are, and they find ways of rearranging their schedule. Or they find things that are most important to them and find ways of integrating MS into that. So finding, for example, if prior to coming to Hopkins, I was out in Washington, and hiking was obviously a very popular activity to do out there for our patients. And for a lot of them, if they were experiencing physical decline, not being able to hike or do these physical activities was devastating. And so when they were able to connect with the MS Society or with other people with MS and do more group-based activities that accommodated for those physical disabilities, they were still able to integrate those physical activities, find purpose in life, find the self-efficacy that we know is so important for quality of life, and they were able to integrate that puzzle piece effectively. For some people, they're not necessarily able to integrate that puzzle piece as effectively, and that's, again, where rehabilitation psychology can really come into play, because we find the strengths that people already have, highlight those values, and then help them integrate that puzzle piece. So Jane was referred to psychology for depression. And after our initial interview with her, which I'll describe in a bit, we identified several sources of resilience that she already has. She had a very supportive family. She had a long history of good problem-solving skills. She had minimal cognitive impairment, and as Dr. Beier said, when you have cognitive impairment, the interaction of cognitive impairment and depression can make treatment a little bit more challenging. So for Jane, she really had this strength in that she wasn't as affected from a cognitive standpoint. She also had access to adaptive technology and home health care for things like physical therapy, occupational therapy. So when we talk about potentially privilege or access to key resources, she really had a long checklist going of things that could help her. Importantly, she had friends both within and outside the MS community. So this is also an important thing we talk about, that your life doesn't have to be all MS all the time, but rather finding ways of identifying with MS and other ways that MS is completely separate. And finding that balance may be different for each person. And that's, again, a role that rehabilitation psychology can provide. Ultimately, we decided for Jane that her coming in and talking about her grief, talking about her loss, even just in a single session, she felt like she was able to prioritize the things that were important to her. We provided some additional education and resources, and we decided ultimately that additional treatment was not indicated for her. She was experiencing a normal grief reaction to a role loss. Talking with a rehabilitation psychologist was helpful, and from there she moved on to use her existing resources. That's sort of an ideal scenario when we talk with patients. At the same time, should she experience additional decline, our door is always open to come back to clinic and initiate therapy if she were experiencing a major depressive episode or a diagnosable anxiety disorder. So that was Jane. To provide a different example, I'd like you to think about Anne. So in contrast to Jane, Anne is a 29-year-old female, and she was diagnosed 2 years ago. So she's fairly early in her disease. Also working full-time, she was reporting significant self-reported symptoms of cognitive dysfunction, but also significant physical symptoms such as vertigo and dizziness. And these symptoms were giving her significant anxiety. Anxiety to the point of she was afraid to drive, and she was having some pretty graphic images of crashing on the highway or fearing that she wouldn't be able to drive anymore for the rest of her life because of these symptoms. When doing a neurological exam with her neurologist, there weren't any physical signs of things like balance issues or vertigo or other physical manifestations of this. It was more of a subjective concern for her. And so that's why she came to us, was that there was a suspicion that a lot of these symptoms were, even if they were physically present to a minor degree, her anxiety was exacerbating those symptoms. And at the time she came to us, she was on a temporary leave from work symptoms, and she had stopped driving because of fear of crashing. So she was referred for both the anxiety and the cognitive symptoms. And most of our treatment really focused on reducing some of those catastrophic thoughts about driving. We talked about using behavioral therapy for driving-related anxiety, and that involved exposure exercises. It also involved having her talk about her MS symptoms and the fear and the uncertainty about the progression of the disease. As a result of those exposure activities, she's now able to drive and use public transportation to get to work. So there's a sort of a compromise of both challenging herself to drive, but also certain days using public transportation, when she is feeling more fatigued or when she is listening to her body and finding these physical symptoms. So again, it's a very different case, but something that rehab psychology can be helpful for. And then finally, I'll turn it over to Dr. Beier for a third example.
So this is an example of a patient that we will call Steve. And the highlight here is that Steve represents how many invisible and visible symptoms can interact together, and how as a primary care physician or another sort of medical provider, you might be able to do something on the front lines to help impact emotional symptoms. So Steve is a 49-year-old male with progressive MS. He had erectile dysfunction, bowel incontinence, and urinary retention. He used a motorized chair for ambulation or mobility. And when asked about things like fatigue, he said he has fatigue every single day, and he has severe pain every single day. Now, prior to his diagnosis, he was what he called a self-described adrenaline junkie. He was very active. He was a construction worker, and so having this progressive illness was really a huge blow to him in terms of how he viewed himself. He's also a guy that didn't really go to the doctor unless absolutely necessary, and so he had sort of this view that he could sort of take this on himself, and was quite embarrassed about symptoms like bowel incontinence and urinary retention. When I talked to him, he was telling me that he had a history of insomnia, but now was sleeping too much. So there was a question of whether or not that fatigue was a factor of MS or something else. And to highlight these two areas of anxiety and depression, he was so embarrassed about his symptoms that he was embarrassed to tell his doctor about sexual, bowel, and bladder issues. So he hadn't told his neurologist, primary care, you fill in the blank. He hadn't told anyone about these symptoms. And that ultimately resulted in him having a bowel accident in public in a restaurant. So after that happened, he completely shut himself in. He no longer did activities with his friends outside the home if he hadn't had a bowel movement in the morning. And he really wondered what others were thinking about him. So he, if he did go into the community, he started to wonder whether people were thinking things about him. After he started to shut himself in, there were days that he didn't get out of bed, he didn't answer phone calls from friends, and he was a previously pretty healthy guy, and he kind of stopped engaging in all healthy activities, including eating well, exercise, and he really just had no interest in doing the things that were enjoyable to him. So my first step with him after learning about this bowel accident and that he hadn't told any of his doctors was to immediately get him in with a physician to address these symptoms. And it turns out that he was able to go to a urologist and get the bladder issues under control. He worked with a GI doctor and a physiatrist to be put on a bowel program so he no longer had accidents in public. And just addressing those two symptoms had a significant impact on anxiety and depression and his ability to engage in functional activities outside the home. But the main thing, too, to highlight here is that he didn't bring it up. So it wasn't until, he came and saw me and I did this really in-depth assessment that he admitted these symptoms. But it's definitely something that could be asked even with a small question here or there, asking about bladder problems or bowel problems in individuals with MS. So especially if somebody is kind of withdrawing from activities, or you notice that maybe there's some warning signs here, it wouldn't hurt to just ask about these symptoms and then refer as needed. So you can do something that might help somebody become more functional and then in response reduce these kinds of emotional distress symptoms. So after we got him in with his physician providers, there was an improvement in mood. He was more engaged in daily activities. He had increased quality of life because he was spending time with friends. And then he realized that talking with his providers was actually helpful and that it could address symptoms that were really concerning to him. So he was more engaged with his medical providers and talking about symptoms.
So to highlight what Meghan was saying, for a lot of our patients, they're embarrassed to talk about certain symptoms, especially mood, bowel and bladder dysfunction, and cognitive dysfunction, because there's a perception that they're alone or that it's not a common symptom. And so the more that we can normalize that and give numbers or give statistics and say, you know, over 60% of people with MS do experience bowel or bladder dysfunction at some point, it helps to normalize that and people feel more comfortable with disclosing that, even at an initial appointment when things are pretty fast-paced. So in terms of what providers can do, screening at every appointment, both for anxiety and depression, is usually a good place to start. In our ethics system, the PHQ-2, or the Patient Health Questionnaire 2, has been integrated into a lot of our templates already, which is wonderful. It's a validated tool that can help detect depressive symptomatology in people with MS. And it's only 2 questions, so it takes less than 20 seconds to administer. Anxiety, however, is not as commonly administered or asked about. And there are patients who will experience anxiety even if they don't experience depression. So I do want to highlight the GAD-2, or the Generalized Anxiety Disorder Scale 2 item. Again, takes less than 20 seconds to administer. And these 2 scales are composed of 2 questions each. The first one for PHQ-2, which you're probably already familiar with. The first item asking to the degree to which patients have experienced little interest or pleasure in doing things in the past 2 weeks, and then feeling down, depressed, or hopeless. If they score greater than 3 on this measure, that would be a reasonable decision point for referral to psychology services, or at least providing additional counseling or additional referral resources to patients. For the GAD-2, the 2 questions are feeling nervous, anxious, or on edge, again, in the past 2 weeks, what degree, and then not being able to stop or control worrying. We recently presented some research showing that the cutoff score for this is likely a 4. So if the score is 4 or more, it's a very sensitive and specific measure for detecting anxiety. Again, 4 questions, takes less than a minute to administer. It can be very useful in the primary care setting. Other measures you may consider, and again, feel free to take these down if you're interested. These are slightly longer measures. If you did have the time or you wanted to include these in your clinic, they all are less than 15 items per scale, but even 15 items can take a while, so that's why I'm highlighting the PHQ-2 and the GAD-2. But here are some others in case you wanted a list. And then we just have some take-home messages that we'd like to present to you as well.
So we talked about a lot of these, so I'll run through them quickly. MS does not necessarily lead to depression. Some of the most severely depressed patients that we see are actually not depressed and are quite resilient. Individuals who are depressed with MS don't always act depressed. They can look like they're irritated, irritable, or have anger. And sometimes having a family member corroborate symptoms or using the validated tools that Dr. Hughes just mentioned can be really helpful. Many patients that we see are very resilient and may only need to meet with us a few times to sort of figure out where to fit MS or these new symptoms into their life. And we can help facilitate this process. And we can also, if it is a more significant mental health issue, we can spend a greater amount of time or do more in-depth treatment that might be helpful. We know that cognition and emotional distress sometimes go hand in hand. So if people are reporting cognitive changes, it might be a red flag or maybe a bit of a light bulb to say I might ask about depression as well. And it might be helpful to refer for a cognitive assessment, especially in MS. Sometimes getting a baseline cognitive test if insurance will cover it, could be helpful in terms of seeing where people stand as they live with the disease or as it progresses. It's also helpful to understand how family involvement might support an individual that you're seeing. Again, as I said earlier, screening for suicide is not going to make it more likely. It actually will decrease the likelihood that somebody will act on suicidal thoughts. That depression, again, goes hand in hand with cognition, and many patients are really motivated to change or to address these symptoms, but they don't know where to start. They don't know who to ask about these symptoms.
So to address the participant's question regarding how to refer to us, again, this can be done through Epic, and you can also call our clinic. And again, we're the PM&R department outpatient clinic, so that can be submitted through Epic or by paper. Every patient that we see, we meet for 90 minutes for a full intake appointment, and this is a thorough clinical interview to then determine if a patient would benefit from things like a cognitive assessment. So if you're not sure whether your patient needs a cognitive assessment or not, you don't have to worry about that. We can meet with them for that initial appointment and then help with that decision-making process. We'll determine some preliminary recommendations about whether cognitive assessment or psychological testing is indicated, and then importantly, refer for other services and see if any additional interventions would be effective. So our return visits then, there are several therapies available. Our appointments are typically 45 to 60 minutes, and that includes individual therapy, couples therapy, and family. We also collaborate with our other PM&R providers, including physiatry, PT, OT, and speech. Just quickly, the focus of our talk today was not to go into the details of the kind of therapy we do, but we do offer cognitive behavioral therapy, acceptance and commitment therapy, and trauma-focused therapy, all of which have been shown to be validated and helpful for people with MS, depending on what their symptoms are. And again, part of that intake process can be a discussion with the patient to see which therapy might be most helpful. So if you do have questions as a provider, you can always reach out to us individually, but we can also meet with the patient too to see what would be the best fit for them. Just a quick note about the MS Precision Medicine Center. So this is a huge endeavor by the Department of Neurology and the MS Center, which is directed by Dr. Peter Calabrese. It includes over 10 neurologists and MS nurses. We've provided the link here. And Dr. Beier and I, while we are not part of the Department of Neurology, many of our referrals end up coming from neurology, and we work very closely with Dr. Calabrese and the other neurologists. So we're very collaborative and interdepartment, both from a research standpoint and clinical standpoint. And then even within our own department, we have our MS Rehabilitation Center, which again is in collaboration with the MS Precision Medicine Center. And our team consists of Dr. Alex Sandoval, who's our physiatrist who has expertise in MS, Dr. Beier and myself, Pei Ting Lian, who is our physical therapist who works with many of our MS patients. And then we also have a number of PT, OT, and speech therapists through the Brain Rehabilitation Program, all of whom have experience working with individuals with MS and are happy to do so, both at the JHH location and at Green Springs Station. So in summary, again, mood symptoms are common, but it may not be brought up by patients, so screening is critical. We hope that the resources we provided you today are helpful or something you may consider integrating into your practice. And again, the mental health treatments that are available and effective, both through Hopkins PM&R, and we can provide additional community referral resources. So with that, we want to make sure we had a few minutes for questions for anyone in the audience, either through the chat box or by phone. So thank you so much for your attention.
Okay, well, apparently someone's typing.
So for those, so for Dr. Pichard, and I apologize if I butchered your name, For those with depressive symptoms and not thought to be adjustments, or any meds shown to be better in MS, SSRI versus SNRI. There actually has been a little bit of work looking at SNRIs in terms of fatigue management. And so for a lot of patients, there has been some modest improvements in terms of fatigue and then sort of downstream effects on depression symptoms with SNRIs. But to my knowledge, there has not been actually a head-to-head comparison comparing an SNRI versus an SSRI. That's something that still needs to be determined. So there are patients who seem to benefit from maybe the dopaminergic aspects of an SNRI, but the degree to which that would help more than an SSRI remains to be determined. Just a quick note about that as well is that we also work closely with psychiatry, and we make lots of referrals to neuropsychiatry providers both at Hopkins and in the community. As one, I'm not a prescriber, and I do not make recommendations in terms of medication. But certainly, if that's something that patients are interested in, we work closely with the PCPs and neurology and psychiatry for those needs.
Okay. If we don't have any other questions, we'll give you back the remainder of the time. Julie seems to be typing. Okay.
Thank you, everybody. Thank you. Appreciate it.
Thank you, Dr. Beier, and thank you, Dr. Hughes. You all have a good day. And just a reminder that the code for the webinar is 12832. Have a good day.
Thank you.
Thank you.
Bye-bye.